Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, and this is Cardiology Board EKG Interpretation. On our YouTube channel, we have more than 300 cardiology lectures. We welcome you to watch them, which will be quite useful for managing your patients in the hospital, in the office setup, or for taking internal medicine or cardiology boards or even nursing boards. Before going any further, I would like to tell you I have created a manual which has 250 pages of very useful information, all the way from history taking to medications, the tests that you order, all the way up to 2022 ACC AHA guidelines. And at the end of the presentation, I'm going to tell you how you can get a copy of this. I also have an EKG book, which is on Amazon.com, but I have created a video for each chapter in this book on our YouTube channel, and you can watch them and gather some information. The feature presentation is a Cardiology Board EKG Interpretations, Electrical Axis and Hypertrophies. And if you have taken a Cardiology Board prep course, you will be familiar with this answer key sheet that is used for interpreting the electrocardiograms in the cardiologist's EKG section of the cardiology medicine boards. So I have done an overall presentation on this template itself, which you can watch, and I also have separate presentations for each one of these boxes, talking all the way from general features, atrial rhythms, junction rhythms, atrioventricular conduction disturbances. The focus of this presentation is going to be voltage axis hypertrophy, and we're going to focus on this one. And in the upcoming presentations, we'll be covering all these metabolic and congenital disorders, intraventricular conduction delays like bundle branch blocks, hemiblocks. Then the most important topic would be myocardial infarction and ischemic changes, along with pacemaker changes. So let us continue with the axis changes and hypertrophies. Another important thing that is covered here is the low voltage in the limb leads and chest leads. And here is the evidence of low voltage in the limb leads. The chest leads have more than 10 millimeters. So basically, if the voltage in the limb leads are less than 5 millimeters, and in the chest leads, if they are less than 10 millimeters, it is considered as low voltage. Sometimes we can see low voltage just in the limb leads. Sometimes we can see low voltage in the anterior chest leads, which may be related to the lead placement. If you place the leads in the second intercostal space, everything going away from the heart can give you a QS complex all the way across, like what we see here pretty much. And also in patients with various medical conditions, which I'm going to talk about in a minute. So here are some of the causes for low voltage on an electrocardiogram. It could be hypothyroidism, pericardial effusion, pneumothorax, infiltrative heart disease such as amyloidosis, sarcoidosis, or lead misplacement, which is an important consideration because especially in patients with large breasts, there is a tendency for people to just put the leads all the way across close to the clavicle, and that's where you see negative QS deflections in the anterior leads. Improper voltage standardization. The first thing you do is when you're reading electrocardiogram, you look at the standardization, make sure it is full standardization. Then, of course, digitalis effect. And here's another example of low voltage in the limb leads because the R waves are less than 5 millimeters. And in the chest leads, the negative deflections are more than 10 millimeters. So I would say, for the most part, you see low voltage in the chest leads also. And there's also an incomplete right bundle branch block because of the presence of the RSR prime changes noted in the electrocardiogram. When we look at these changes, we always need to think about what is causing this, especially if this is in the context of a case presentation. The EKG could be an important clue as to what the examiners are looking for in the overall history, overall presentation of this patient, and as what tests you order and how you manage those patients. Also, if you look at the STT segments, they are also important. And here is an example of low voltage in the chest leads compared to the previous electrocardiograms, but the limb leads show a pretty good voltage. We can see these kind of changes in the presence of significant myocardial damage, significant myocardial infiltration, or significant myocardial scarring. So that's another important consideration to take into account when we are looking at low voltage on an electrocardiogram. So we have to, cardiology is all about putting the whole pieces of the puzzle together to come up with a composite analysis of what this patient has, what tests we need to do, and how we manage these patients, and how well we communicate our messages to the patient and their families. Okay, here is a beautiful chart looking at low voltage from two different mechanisms. One is impedance, the other one is generation of the electrical impulse itself, which may be related to myocardial infarction, cardiomyopathies, myocarditis, or hypothyroid heart disease, myxedema. Whereas there could be impedance to the electrical impulse from getting to the chest wall from the heart. And these conditions would include, of course, effusion, pericarditis, pneumopericardium, and pneumothorax, and a whole bunch of conditions that distances the heart from the chest wall, thus reducing the voltage most predominantly in the precordial leads. Peripheral edema, obesity. This is an example of a sinus rhythm. There is reduced voltage in the chest leads, except for V2, which doesn't quite make it to be 10 millimeters. So there's reduced voltage in the chest leads, whereas in the limb leads, there's reasonable voltage. Here's an example of reduced voltage in the alternate beats. It's also called as electrical alternance, and whenever we see electrical alternance, we have to think about conditions that can cause electrical alternance. One is like a swinging heart that we see in patients with large pericardial effusions. See, the electrocardiogram is almost like being a detective as to where the heart has been, where the heart is here today, and where it could go in the coming days. Especially if you're dealing with a acute myocardial infarction, you can expect evolutionary changes as time evolves. Okay, the next we're going to move on to the electrical axis of the heart. A lot is being said about electrical axis of the heart. Electrical axis of the heart, it tells us about some conditions within the heart that may be a clue as to how significant the underlying cardiac problem or problems are and what we need to be aware of. The presence of electrical electrical axis abnormalities are fairly uncommon, but nonetheless, when they are present, they certainly signify a significant underlying etiology. And let us look at some of the things that can. The normal electrical axis is between minus 30 degrees and plus 100 degrees. This is how the impulse travels, and that's why we get. This is how the impulse travels from the sinus node to the AV node, and from there it spreads to the right and the left ventricle. So the whole impulse is going downwards and forwards towards the apex, and we get an axis which is predominantly between minus 30 degrees and plus 100 degrees. Anything beyond minus 30 towards the left shoulder is considered left axis deviation. If it's more than minus 45 degrees, it is considered as left anterior hemiblock. I'm going to show some pictures of those. Whereas if there is an axis greater than 100 degrees, you're talking about right axis deviation, which may be related to right ventricular hypertrophy, or it may be related to the left posterior fascicular block. So these are all terminologies we need to get familiar, and there's a quick way to find out what the axis is. They're not going to ask you precisely what is the degree of axis, like is it 47 or 48, But they are going to expect you to see, does this patient have left axis deviation, left anterior hemiblock, right axis deviation, normal axis, or indeterminate? You're not going to get indeterminate axis, I hope. And here's how electrical axis is plotted in like a pie chart. The normal axis is between AVL, and the best way to determine what is the electrical axis is to look at two leads, which I'm going to show you in the next couple of slides. And by that, you can pretty much narrow down what range the axis is going to be. So keep in mind, lead 1 is always positive. Anything that is positive will come on this side. Whereas lead 2 can be positive, or it can be negative, or it could be biphasic. Lead 2 is extremely important in identifying the electrical axis. A simplistic approach is to look at a lead in the EKG which has equal positive and negative deflections. That means if the lead 1 is positive 5 millimeters and negative 5 millimeters, the axis is perpendicular to that, that is 90 degrees, which is normal. So that's a very quick clue as how you determine. First, I will look at a lead which is isoelectric, as it is called, where the positive and the negative deflections are of equal height in terms of millimeters. And this is an example which we're going to be using to determine the electrical axis. Remember, this is the normal axis. This is the left axis deviation and also left anterior hemiblock when this is more than minus 45 degrees. And this is a right axis deviation. This we don't get concerned with because it's extremely rare to see an extreme right axis deviation. Okay, here is an example of lead 1. Lead 1 is more negative than positive. So what does that mean? The whole electrical axis is going to be this side on the left, that is between plus 90 degrees and minus 90 degrees. All right, and if you look at lead 2, which is almost isoelectric, that means the positive deflection is equal to the negative deflection. That means your lead is here, so this has to be 60 degrees plus, if you put 90 degrees, you are looking at right axis deviation. And that is also substantiated by the fact that you have a positive deflection in AVR. So this axis is 60 plus 90, so it's going to be perpendicular to that and beyond. So it's going to be more than 150 degrees. So this is 120. So this is a case of an extreme right axis. And you always worry about if it's lead misplacement. Lead misplacement can cause right arm, left arm. Lead misplacement can cause right axis deviation. But look at the P waves. That will be a clue that you're not dealing with a lead misplacement. If it's a lead misplacement, your P waves will also be inverted. There'll be a mirror image of AVR in lead 1 and lead 1 in AVR. All right, here is an example of a negative deflection that is more in depth compared to the positive deflection. That means we have more negative deflection. So this means it is minus 30 degrees and beyond. And by the same token, lead 2 and 3, lead 3 and AVF, 3 and ABF are all negative. That means it is more than minus 30 degrees. So we have left axis deviation plus left anterior hemiblock. Remember, left anterior hemiblock can have left axis deviation also, whereas left axis deviation doesn't necessarily mean that you have left anterior hemiblock unless the axis is more than minus 45 degrees. That's where they can trick you. Here is a little quick tip to identify the electrical axis by just looking at 3 leads. Lead 1 is positive. It is in this half of the circle. Lead 2 is positive. It is in this half of the circle. If ABF is positive, you're looking at the bottom half of the circle. So by combining any one of these 2 leads, you can determine what quadrant you're in. And you can take the third lead and narrow down the degrees from 0 to 90 or 90 to 180 or 0 to minus 90 degrees. And that's how we can very quickly determine by looking at lead 1, 2, and ABF. Let's do some examples here and see what we can determine. Okay, here lead 1 is positive. That means we are looking at this segment of the cycle. Lead 2 is more negative than positive. So lead 2 is more negative. That means we are looking at this segment of the cycle. So we started off here, so it is no longer this bottom half, so it's going to be the top quarter of the segment. And if you look at the rest of the leads, 3 and AVF, they are all negative. So you are looking at an axis that is in this quadrant, which is more than minus 30 degrees. So I would call this as left axis deviation and left anterior hemi block. The Japanese did a study looking at 4,444. That's a pretty interesting number. People who had echocardiograms and ECGs. People who had echocardiograms and ECGs, and interestingly, 92% of them had normal axis, that is between 0 and 110 degrees, whereas 5% of them had left axis deviation and only about 2.8% had right axis deviations. So they are not very common, but when they are present, it is of importance, and also it is important because of the board exams. All right, here, what are we looking at? Here, your lead 1 is more negative than positive. So we are looking at this segment, the left half of the circle. Then lead 2 is positive. 3 AVF, these are all positive. That means lead 2 is going to be positive. That means it's going to be lead 2 is positive. Lead 3 is positive. AVF is positive. So you are looking at anywhere from 90 to 180 degrees. So this is right axis deviation, and also this patient has a right bundle branch block, which can cause a slurred S wave in the limb leads and also in the chest leads. You can see the slurred S wave. Here's an example of a right bundle branch block, which is pretty obvious here, and there's also left axis deviation. And by looking at that little chart I showed in the previous one, there's more negative deflection in lead 2, and that means it is more than minus 30 degrees. So you're looking at left axis deviation, left anterior hemi block, right bundle branch block, and you may also want to measure the intraventricular conduction interval. And so we are looking at bifascicular block. When you're looking at bifascicular block, we also need to think about high-grade AV block, or maybe trifascicular block if the PR interval is greater than 200 milliseconds. Here, the PR interval is normal, but when we see something like this, as a cardiologist or a primary doctor, we need to be concerned about, can this progress to higher degrees of AV block or rhythm disturbances. Now we're going to move on to the next chapter here, that is ventricular hypertrophy. First, we're going to look at the criteria for right ventricular hypertrophy. Then we're going to look at criteria for left ventricular hypertrophy. The right ventricular hypertrophy criteria are presence of right atrial enlargement, prominent RS patterns like taller R wave and a smaller S wave in V1 and V2. Discordant STT segments, that is hypertrophy with strain. Your hypertrophy, tall R waves, strain, which is downsloping ST segment and T wave inversion. So those are important things. Then we have a RS pattern in lead V1 to V5. Is S suggesting this more rightward deflection of the impulse. Then, of course, right axis deviation. All right, let's look at some example. Here we have a right axis deviation because the negative deflection in one is greater than the positive deflection. And also we have tall R waves here with actually no S waves, but here you see some terminal S waves. So we have right axis deviation. This the P waves, which look pretty prominent. That's 1 to 2.5 millimeters. We have right atrial enlargement, right axis deviation, and right ventricular hypertrophy. So these are some of the features. Plus we also have discordant STT changes. Of course, this is a computer-generated EKG, but let's look at this an example of a left axis deviation and a left anterior hemiblock, because the negative deflection is much more than the positive deflection. That means it is beyond minus 30 degrees. So we are looking at the left axis deviation, left anterior hemiblock, and also there's a prominent negative deflection in V1 suggesting left atrial enlargement. So when you look at these kind of changes, you also wonder, is there anything else? Well, if you add the voltage here, you see the voltage between S in V2 and R in V5 suggests left ventricular hypertrophy with strain. So I told you an EKG is like an inside look into what's actually happening in the real heart. So we have left axis deviation, left anterior hemiblock, left atrial enlargement, left ventricular hypertrophy with strain pattern. Where do we see these conditions? Patients with hypertension, aortic stenosis, mitral regurgitation, or hypertrophic cardiomyopathy. So these are the things that should come into our mind as we look at the electrocardiograms. Okay, now let's look at left ventricular hypertrophy. Of course, left ventricular hypertrophy is characterized by high voltage in the lateral chest leads, left atrial enlargement, STT changes in 1, ABL, V5, V6, which I already showed you in the previous example, and biphasic P waves in the inferior leads. Let's go back and see if we see those. You see biphasic P waves in the inferior leads, and the second peak, which is the left atrial activity, which is higher than the right-sided atrial activity, left atrial enlargement, increased voltage, and discordant STT changes. Every word is important in trying to pin this together so it meets all the criteria that's explained here for left ventricular hypertrophy with strain, left axis deviation, left atrial enlargement, and left anterior hemiblock. One of the most important things that you need to memorize as a cardiologist or as an internist is which is very well known as the Estes criteria for left ventricular hypertrophy. Actually, it is Romhild-Estes criteria, but for most practical purposes, you're going to hear the term Estes criteria. So let's get familiarized with Estes criteria. The points are given to various aspects of the electrocardiogram, either the R waves, the S waves, the ST segments, left atrial enlargement, axis, all this together comes up. Then if you have more than 5 points, it is definitely indicative of left ventricular hypertrophy. That is an R or an S in any limb leads greater than 20 millimeters in height, or S in lead V1 and V2 greater than 20 millimeters in height, or R wave in V5 or V6 greater than 30 millimeters, 3 points. Left ventricular strain, that is downsloping ST segment with a T wave inversion, and downsloping ST segment with a T wave inversion, downsloping ST segment with inverted T waves, that is 3 points. And I hope you can see my arrow here. Digitalis effect, then you get only one. If the patient is on digoxin, you get only 1 point. Then if the left atrial abnormality is there, 3 points. Or if a patient has atrial fibrillation, that can be substituted to the left atrial enlargement. Left axis deviation, 2 points. QRS duration of more than 90 milliseconds, you get 1 point. And intrinsicoid deflection, that is how long it takes for the R wave to peak. If it's more than 50 milliseconds, you get 1 point. So you have a maximum of 13 points, but if you get 5 or more, it is left ventricular hypertrophy. And there's another one, Sokolov-Lin left ventricular hypertrophy, which looks at S wave in V1 plus R wave in V5 or V6, which is greater than 35 millimeters or 3.5 millivolts. That is suggestive of left ventricular hypertrophy. Then let's look at some examples here. Okay, we got tall R waves here. And we also got tall R waves in the anterior leads. We also have tall R waves in the lateral chest leads. We also have negative downsloping ST segment or horizontal ST segment with the inverted T waves. left atrium looks okay, the right atrium looks okay, so axis looks okay. So basically we have left ventricular hypertrophy and also right ventricular hypertrophy. So this is an example of left ventricular hypertrophy with strain, and because of the presence of prominent R waves in V1 and V2, also the presence of right ventricular biventricular hypertrophy. I wish we could have seen some more changes in the atrial activity, but we don't. And here's an example of a left ventricular hypertrophy with strain pattern, because you can see extremely tall R waves and deep S waves, then downsloping ST segment and T wave inversions, which are characteristic of left ventricular hypertrophy with strain. And this is known as the discordant STT changes. They are going in the opposite direction of the QRS complex. And there's also a deeply negative deflection of suggestive of significant left atrial enlargement or electrical abnormality of the left atrium, and also a peaked P waves, which is suggestive of left atrial enlargement. Sometimes we see ST elevation and tall T waves. That doesn't mean there's anything pathological as far as hyperkalemia or ischemia like that. That is seen frequently with left ventricular hypertrophy, and also in patients with the left bundle branch block we see similar changes. And here's an example of what I was talking about, the significant ST elevation of almost like 3 millimeters or so, but this is a good example of left axis deviation, left anterior hemiblock, left ventricular hypertrophy with strain, and also some ST elevation, which is a normal variation of the left ventricular hypertrophy. So it is not suggestive of like an acute ischemia or something like that, but it is part of the left ventricular hypertrophy. And here's an example. Oh, here's another thing I wanted to say. There's also intraventricular conduction delay. It's more than 90 milliseconds. It's almost like 110 milliseconds. So it's not quite characteristic of left bundle branch block, but there is increase in that's called the intraventricular conduction delay. That's something all right, here's an example of another left ventricular hypertrophy with strain, and look at the ST segments here. They look like 5-6 millimeters, but that's a normal variation. So it is not suggestive of hyperkalemia or acute myocardial injury, but this is part of the left ventricular hypertrophy. The best way to know if it has any significance is to look at the previous electrocardiograms, look at the presentations, and obviously the clinical presentations and lab tests will prove that to be part of the normal changes that we see with significant left ventricular hypertrophy with strain. Here's an example of right axis deviation, peaked P waves, significantly increased voltage, completely positive deflection in V1, V2, and much more significant than we see in the lateral chest leads, and there's discordant STT changes. So what are we looking at here? Well, first of all, we have right ventricular hypertrophy, and also we have significant right axis deviation, and maybe some atrial enlargement. When we see these conditions, we need to think about right ventricular hypertrophy. What are the conditions that can cause right ventricular hypertrophy? But also remember, this is a patient 18 years old. So sometimes it could be a normal variation for young children. But when we see such significant changes, we always worry about what are the conditions: congenital heart diseases, ventricular septal defect, or tetralogy, or like left to right shunt. So these are some of the things we need to be thinking about. Here's an example of another case of a right axis deviation, maybe right atrial enlargement, along with some positive deflection in V1 and V2, with some negative inversion, T-wave inversions in the anteroseptal leads. This is an example of a right axis deviation, right ventricular hypertrophy with strain. And here's with a sinus tachycardia, because we see P waves preceding each QRS complex. Again, we see right axis deviation, right ventricular hypertrophy with strain, and there may also be increased voltage in the chest leads, which may also suggest left ventricular hypertrophy. Along with that, there may also be left atrial abnormality. So we are looking at combined right and left ventricular hypertrophy with strain. So ladies and gentlemen, that is a quick overview of electrical axis, how you quickly determine what segment the electrical axis is, and how to determine whether we're dealing with a right ventricular hypertrophy or left ventricular hypertrophy or biventricular hypertrophy. The way you can get this book is to send me an email to drniknikam@gmail.com, and I'll be happy to send you this copy. And please do subscribe to our YouTube channel, and tell your friends to subscribe to our YouTube channel so they all can benefit. I am Dr. Nik Nikam. This has been a presentation of Triple N Media. Please do follow us on our YouTube channel. I will see you in the next presentation. Thank you so much.